Доброго дня.
Доброго дня, шановні колеги. Ми починаємо. Марина, мікрофон.
Дякую. Шановні
На
колеги,
ссылку нажала, вот уже она говорит, но я ничего что-то не слышу. Вот Марина Кучер.
так, і шановні учасники, перед тим, як ми почнемо, давайте домовимось вимикати мікрофони на той час, коли ми не хочемо, щоб нас чули, і вмикати тільки тоді, коли почутиме. Що ж, нагадаю, давайте розпочнемо чергову сесію знайомства. І хто тут хто? Мене звати Марина Кучер, я консультантка офісу ВОЗ з ВІЛ, і сьогодні буду фасилітувати нашу сесію. Разом зі мною колеги з українського та також регіональних офісів ВОЗ. Рада представити Іоанніс Мамелетціс, це консультант з ДКП офісу ВОЗ. Також з нами українська команда, яку представляє Газалова Ктай, Олександра Стражевська і Ольга Зайцева, також Дмитро Мірошниченко. І з нами сьогодні від Центру громадського здоров'я МОЗ України Діана Шевченко. Ми будемо вас супроводжувати протягом цього дня. Підсумовуючи перші два, хочу нагадати, що ми пройшли структурно по глобальному контексту, як працює ВОЗ в ДКП, які є нові інновації і що вже зроблено і що є в планах на наступного кроку. Проговорили всі аспекти, всі потенційні варіанти, а також зосередились на тому, що є завжди вибір. І саме питання цього вибору ми розкриваємо протягом наступних сесій, 2-го і 3-го дня, запрошуючи до нас нових спікерів з нових країн, щоб побачили, які є альтернативи у доконтактній профілактиці. І так, з нами другий день була докторка Рупа Патель, перепрошую, з Сполучених Штатів Америки, і пацієнти, які приймають вже кабетогравір 2 роки, з чим вони згодні підтримувати Україну надалі у впровадженні, і ми сподіваємося, що у наступних заходах вони також, докторка Рупа, прийме участь і буде підтримувати Україну надалі. І сьогодні в нас ще 2 країни, 2 нових материка. Це з Південної Америки, в нас з Бразилії лікар і пацієнт, і також у нас буде ще Південна Африка. Тому на цьому я би хотіла, власне, перейти вже до сьогоднішнього дня, до структури. Як я сказала, з Південної Африки в нас буде доктор Кетрін Мартін. Вона лікарка, яка має експертизу в підлітковому здоров'ї, сексуальному та репродуктивному здоров'ї. Вона також біомедичній профілактиці ВІЛ та, в принципі, зміцненні системи охорони здоров'я. Вона очолює команду з впровадження науки, яка займається інтеграцією нових профілактичних продуктів, включно з, власне, довготривалої доконтактної профілактиці у медичні послуги. Після цього, після її презентації, в нас буде виступ пацієнта. З нами тато на зв'язку. Він розкаже вам свою історію та досвід використання доконтактної профілактики, там, бар'єри, мотивації та вплив. Він також з нами сьогодні на зв'язку, тому буде можливість задати йому питання. І після цього ми переключимось на іншу вже країну, Бразилію. З нами доктор Бренда Хогланд. Також лікарка та клінічна дослідниця, яка активно працює над впровадженням кабетогравіру тривалої дії Державної системи охорони здоров'я Бразилії. Вона поділиться моделями, які дозволяють. Так, і після цього в нас буде можливість у всіх задати питання.
Зараз я виключуся, бо я на ДКП. Ще тут на другому включено? Це ще навчання третій день
Я хочу
ДКП.
нагадати, будь ласка, вимикайте мікрофони, якщо ви не хочете, щоб вас чула вся
Зараз через це підключаюся, бо воно щось...
А в питаннях сесії, відповіді та запитань ми будемо дуже раді бачити ваші вимкнені мікрофони. Що ж, на цьому я передаю слово доктору Кетрін, і ми розпочнемо наш навчальний захід.
Thank you so much for the opportunity to present. Can I just confirm you will be putting up the slides?
Yes, we will turn on the slides because they are in Ukrainian and they will...
Yes, good. Okay, so I can start.
Let's confirm. Yeah, you can see everything well.
Sasha, it's downloading. Yes, full screen, please, and we can...
Excellent, excellent. So just let me know when to switch to the next slide.
Perfect, thank you, will do. So thank you so much for the opportunity to present some learnings from South Africa. I will be sharing some experience through Wits RHI's work on PrEP introduction, focusing on our community and youth-focused delivery models. And I will also share some experiences with the introduction of Cabernet injectable PrEP, and I'm joined by my colleague Tato Mtsweni, who will share some of her experiences from the community perspective. Next slide. South Africa has achieved among the highest PrEP initiations globally. We have initiated over 2 million people on PrEP. However, although global initiations have reached many millions, there is still a high unmet need for HIV prevention. Next slide. Next, yeah. Oral PrEP was introduced in South Africa in 2016. It was initially provided to sex workers and men who have sex with men, and was expanded to adolescent girls and young women at selected sites in 2017. By 2018, oral PrEP had been introduced more widely, and Wits RHI has supported the Department of Health to introduce oral PrEP in primary healthcare settings at scale. In August 2023, implementation study sites began offering the ring to eligible women. And in April 2024, sites began offering injectable PrEP, Cabernet, as an additional HIV prevention option. We are now actively preparing for the introduction of lenacapavir. Over this period, South Africa has initiated over 2 million people with PrEP, with 450,000 new users initiated in 2024. Almost all of our primary care public health facilities offer PrEP through over 4,000 service delivery points. Next slide. Key to the success of South Africa's PrEP program is that it's led by the Department of Health and embedded within integrated primary healthcare services. Although all the PrEP methods are registered for use in the country, only oral PrEP and very recently lenacapavir are included in our essential medicines list, which facilitate their use through the National Public Healthcare Program. Oral PrEP is widely available through Department of Health facilities. Sorry, should I? Sorry, should I continue? Okay.
Mute that
Continue. Okay. PrEP is primarily provided through trained nurses in public healthcare facilities. Oral PrEP is accessible free of charge to HIV negative people who could benefit from or who request PrEP. Next slide. Wits RHI, the organization where I am based, has supported PrEP introduction through 3 major implementation projects. The first is the UNITAID-funded Project PrEP, which has been implemented since 2018. It's focused on reaching girls and young women and has supported the introduction of oral PrEP, the ring, and injectable cabotegravir through integrated PrEP and sexual and reproductive health services in 8 primary care clinics and 4 linked mobiles. The USAID-funded DREAMS program was implemented between 2019 and 2025, primarily reaching girls and young women through community-based delivery models and service points linked to learning institutions. The USAID-funded Catalyst study was an implementation science study amongst girls and young women, older women, transgender women, and sex workers, which spanned 5 countries, including South Africa, with the sites in South Africa comprising 6 facilities, 2 of which were dedicated to services among key populations. Next slide. But innovation in product also needs delivery innovation in order to reach success. The World Health Organization has provided implementation guidance on differentiated and simplified PrEP for HIV prevention, outlining building blocks for differentiated service delivery, categorized into where services are located, who provides services, when and how often they are provided, and what is included in a service package. Next slide. Understanding end-user preferences is really central as we think about how to deliver PrEP options in ways that people will actually use. When we asked over 300 adolescents and adults about their preferences for HIV prevention services, the message was clear that people want convenience, autonomy, and digital connection. Digital platforms, especially online and social media, were preferred over printed materials for HIV information. Pharmacies, home delivery, and vending machines were more popular than clinics for picking up PrEP, and most people wanted 6-monthly visits, not quarterly visits, and there was a strong preference for self-testing over provider-led testing. WhatsApp and Facebook peer groups were also valued, showing how much people want ongoing support between visits, but in a way that is accessible. Interestingly, pop-up sites were least preferred for PrEP initiation, showing that people still value trusted, familiar spaces like pharmacies and clinics. Next slide. We know that structural barriers remain a challenge to PrEP access. In the South African context, this includes school and work scheduling conflicts, distance from service delivery sites, clinic operating hours, long waiting times, and healthcare provider attitudes. Differentiated and decentralized services hold the potential to address some of these issues and have been a central component of Wits RHI's innovative PrEP delivery models. Next slide. Wits RHI has implemented community-based service delivery models, including mobile clinics, pop-up gazebos in community locations, services linked to colleges and universities, and services linked to secondary schools. The services are integrated, and the mobiles and gazebos branded in attractive, colorful, youth-friendly feel to enhance engagement and minimize stigma. Next slide. Through Project PrEP, Wits RHI implemented mobile clinic services in 4 areas of South Africa. Of the over 65,000 clients who were reached through the project, approximately a third were reached through mobile services, the majority of whom were adolescent girls and young women. Across mobiles and fixed facilities, PrEP uptake is high at approximately 70%. Next slide. Next slide. Oh, I think it skipped one. Sorry, one back. There, sorry. The DREAMS project delivered a community-based model, reaching over 270,000 people with PrEP, the majority of whom are young women. These services are linked to higher learning institutions or delivered through community sites. They're either provided through a mobile clinic, which includes a consulting room, or through a pop-up gazebo where there's a foldable bed and table within the gazebo. Next slide. At the center of these service delivery models is engagement with communities and peers. Peers play a vital role in comprehensive prevention, HIV prevention, and sexual and reproductive health services. Wits RHI works with peer ambassadors, also known as our community information agents, who are experts on PrEP and in their communities. We work with them to develop community-led demand creation models that link online engagement, outreach, and clinic pathways. We co-create demand creation materials and activities which improve their relevance, buy-in, and scalability. We also support peer ambassadors to generate online materials, which facilitates engagement through their influence and connection with other young women online, helping to convert engagement into action. Next slide. Here are some examples of our peer ambassadors who've taken their own testimonials and creatively designed vibrant posts that have been shared on the MyPrep South Africa's Facebook page. Next slide. Service integration is essential to provide health benefits beyond just HIV prevention and PrEP. In our context, young people have multiple intersecting health needs, including high rates of STIs, gender-based violence, mental health and depression symptoms, and an unmet need for contraception. Integrated services provide an opportunity to enhance HIV testing, contraception provision, STI screening and management, mental health screening and referral, and to improve PrEP uptake and effective use. The papers that are highlighted here provide some specific data on these health needs and the tangible benefits of service integration. Next slide. PrEP integration also creates efficiencies. Among over 3,500 people who were enrolled in a Project PrEP cohort, offering a choice of PrEP methods, the vast majority were also screened for STIs, TB, and mental health symptoms, and gender-based violence, a strong signal that comprehensive care is possible within prevention programs. Focusing on women specifically, of the 3,000 who chose a PrEP method, 76% were already using a contraception or received one during the visit. And importantly, nearly half of those women received their contraception the same day as their PrEP appointment. This tells us that integrated services are happening and that same day, same place delivery of prevention and reproductive health care is feasible and valued. As we introduce new PrEP products, this kind of efficient integrated care, it remains a priority. Next slide. So I will just move to sharing some lessons learned from delivering Cabalet in particular. Next slide. Building PrEP awareness isn't a one-time campaign. It's a continuous process that must be rooted in community. Within Wits RHI, we center HIV prevention around the people and places it's meant to serve. This means working closely with community-based organizations, our youth ambassadors who guide our messaging, our language, and our approach. Our platforms are active and effective. Our Facebook page reaches nearly 200,000 people a month, and these digital platforms, along with our offline efforts, are easily adaptable to promote other emerging PrEP options. If we want to reach scale and equity, we need to keep raising awareness consistently, creatively, and together with communities. Next slide. We spoke with 34 healthcare providers in South Africa to understand what is working or hindering the delivery of PrEP choice. What worked? Providers emphasized the importance of consistent and clear messaging throughout the client journey, supported by tools like pamphlets, and when we were introducing the ring, the demo rings as well. Just as important were positive provider attitudes, ongoing peer learning, and tailored training for different roles. There were some real challenges: time and space constraints, a perceived increase in workload, and missed follow-up visits that disrupted continuity of care. Some providers and clients expressed some uncertainty or mistrust of newer methods, showing that both confidence and capacity need to be built as we introduce new PrEP options. But if we want providers to enable informed choice, we do need to invest in them just as much as we invest in the new products. Next slide. This is the baseline data from the cohort offering a choice of ring, oral, and Cabalet PrEP. And we saw across all population groups there was strong demand for injectable PrEP. PrEP. Preference for Cabernet was consistent across these groups, especially high among older women. However, there was still a substantial proportion who chose oral PrEP, highlighting that choice remains important. Next slide. We've learned that reaching adolescents and young women isn't just about having the right products, it's about how we offer them. When PrEP counseling is done well, it's respectful, clear, and offers choice. Women respond positively when they've shown different options, using visual tools and simple language, not clinical jargon. They value providers who take time, answer questions honestly, and maintain privacy. But when counseling is rushed, judgmental, or confusing, it can be a barrier. As we roll out new products and offer PrEP choice, we have to remember that good counseling isn't optional, it's foundational. It's what turns availability into access. Next slide. Similar to findings from the search study, we also observed that offering multiple PrEP methods increased PrEP coverage. At Catalyst sites across 5 countries, routine service statistics showed a significant increase in the average number of PrEP visits per month after the introduction of PrEP choice. Next slide. And preliminary data from the Project PrEP cohort shows the potential that injectable methods have to increase ongoing PrEP use and engagement. The time to first PrEP interruption was significantly shorter for oral PrEP users compared to those on injectable CAB, meaning people stayed on injectable PrEP longer before stopping. Next slide. And even though CAB has high efficacy and appeal, it's clear that no single PrEP method fits everyone's needs all the time. When CAB was introduced, almost half of the oral PrEP users chose to stay with oral PrEP, while 46% switched to CAB. There were some people at that time who were already using Ring. 59% of them switched to CAB, but 31% remained on the Ring. And some participants who weren't previously using PrEP started on CAB, oral PrEP, or the Ring. These patterns show the importance of offering real choice. People pick what works best for their lives at that moment. Flexible and respectful counseling are key to supporting informed decisions and continued engagement. Next slide. Across these projects and drawing on lessons from South Africa and other countries, multiple tools and job aids have been developed. These can be used to support preparation and implementation of long-acting PrEP methods and are available on the PrEP Watch website. Next slide. So just to end with a few key takeaways, differentiating service delivery allows us to reduce the barriers and access and improve uptake of interventions. We need to meet our clients where they are. One size doesn't fit all. We need product choice as well as service delivery choice, and we need to be adaptive and flexible to deliver services in any setting and circumstance. Communities are central to our demand generation and sustainability. Integrating services allows us to be more client-centric, addressing all aspects of health and wellness. PrEP choice is here. We need to make sure that it's a reality for all by ensuring access. Next slide. I would just like to thank the many people who contributed to this work and to the slides, particularly our funders, as well as the Department of Health in South Africa, and every young woman and community member who has worked with us to shape our thinking and guide our actions. Thank you.
Дякуємо, Кетрін, дуже за презентацію. Змістовний досвід вже успішного впровадження препаратів, інноваційних препаратів. І я думаю, ті виклики, якими ви поділились, вони також були актуальні у нас в Україні. І це так приємно відчувати, що ми не самі на цьому шляху при впровадженні інноваційних продуктів. І я думаю, що це буде дуже корисно для тих бо в Україні насправді тільки в декількох містах вже впроваджено там каботагравір. Ми розширюємо цю програму і будемо далі розширювати на інші міста, і ваш досвід, він буде дуже корисний для тих закладів, представників тих закладів, які тут сьогодні присутні і будуть йти в цьому напрямку так само. Тому якщо будуть з'являтися питання протягом нашої презентації в чаті, ми ще будемо задавати. Оскільки зараз питань немає, можливо, вони ще з'являться, я пропоную вимкнути відео нашої пацієнтки тато.
Так, колеги, я це роблю. Прийдіть лише мені, що ви його будете бачити зараз. Так, колеги, підтвердіть, будь ласка, що ви бачите відео.
Ваше відео не бачимо, бачимо папку третього дня із презентаціями та відео. Але само відео закрито.
Зрозуміло.
Поки нічого не бачимо. Знову бачимо екран із завантаженням.
Відео. Так, колеги, чи бачите ви відео?
Та ще ні папку із завантаженнями. Досі.
Угу, бачу, що ні.
Іоанніс, please.
Sorry, as you guys are trying to get the video up and running, I just had a sort of a question to Dr. Catherine. Catherine, thank you again for your great presentation. We understand, of course, South Africa is also embarking on introduction of lenacapavir alongside the other products. And I was hoping to understand, because Ukraine has received significant doses for Cabolet PrEP, which have already are going to the regions. As we understand it, also there will be a supply of lenacapavir hopefully coming into the country. But it's sort of from the provider perspective and those joining today, I think there's a particular interest, of course, on cabotegravir, hence yourself and our colleague Brenda from Brazil, who's online. So with all that said, I was your kind of viewpoint on some of the preparatory work that needs to go in getting sites that do not have any long-acting PrEP product experience, maybe some level of oral PrEP service delivery, and some of the sort of upstream work to get those sites supported. We've had 3 cities in Ukraine already that have initiated cabotegravir as part of a pilot. So maybe just a few reflections from your end, and then we'll go to Tato's video. Thank you.
Yes, thank you. And I think what has been good in the South African setting is that, as you could see from the data, many of the facilities were already offering oral PrEP. So I think it is helpful when you're building on an existing HIV prevention or PrEP service. But what we have also noted as important is to tailor the services for the people they're intended for. So a lot of our programs are focused on young people, young women. So making sure that they are youth-friendly, that you've tried to reduce stigma, that providers are able to engage clients on all of their health needs. As I also mentioned, a lot of people have integrating health service needs, sexual and reproductive health needs. So having providers who are able to support all of those needs and to offer that client-centric care, to look at what does the person need and how can we integrate and respond to their individual needs in a way that that is not stigmatizing and that really kind of encourages them to use the services. Yeah, so I think that would kind of be one key point. And then I think I had mentioned also some of the demand creation materials, also making sure that those are integrated in perhaps the other services that are available, or that there is a message around HIV prevention and PrEP more broadly, allowing some flexibility then if different methods are available in different places.
Thank you very much, Catherine. And sorry, Marina, over to you and the video. Thank you.
Так, дякуємо, колеги. Будь ласка, давайте передивимось відео на пацієнтки тато, і після чого можна також буде задати їй питання.
Sorry, Marina, I cannot hear. I don't know if there's an issue with others.
Так, Яніс, у нас така сама проблема. Зараз спробуємо вирішити. Зараз давайте паралельно в цей час я переведу питання, яке у нас є, для того, щоб ми продовжили цю комунікацію, поки у нас технічні питання.
Шановні колеги, якщо ви підключені до каналу перекладу українською мовою, то наш перекладач читає скрипт. Будь ласка, включіть глобус українською мовою.
Така в нас була презентація відео з пацієнтом. Можливо, у вас це викликало якісь емоції або є якась рефлексія. Ви можете одразу їх висказати як в чаті, а також голосом в мікрофон. А можливо, поки у вас є час ще підрефлексувати, ми можемо обговорити з нашою лікаркою пані Кетрін. Це те питання, яке виникло в чаті. В нас було питання щодо орального ПрЕП. Чи який варіант тестування пацієнтів в тому варіанті, якщо доконтактна профілактика видається через поштові автомати. Пані Кетрін, могли б ви відповісти на це питання? Як це працює у вас?
Thank you for the question. Our postal services are very poor in South Africa. So no, it's quite a large country, some quite rural areas, quite large distances. So we don't have a good network of postal services. The most feasible access point for PrEP is our primary healthcare facilities, which are supposed to reach most communities, but often there are distances that people have to travel to reach those primary healthcare facilities. But this is where Wits RHI has tried to close that gap by extending the services of those fixed facilities into communities through mobile clinics or the community gazebos. But unfortunately, we don't have good postal services or online access to test kits or to PrEP yet.
Дякуємо, Кетрін. Олександра?
Yes, just I rather have a short comment. First of all, how much I'm impressed with this peer ambassador model, which is so widely introduced in your country, and we know that it's totally aligned with WHO recommendations, and it is highly, highly efficient. So also, Tazo, thank you very much for your honesty and sincerity. And Catherine, just also echoing previous question, I wonder about this low threshold approach, and how do you manage to calculate the unique number of unique patients in case when they receive PrEP via vendoring machines in the pharmacies, etc. Thank you.
I hope I'm understanding you correctly, but we don't currently implement PrEP through the vending machines. In terms of our national program, we have a data collection system that accounts for PrEP initiations, which is from all these primary healthcare facilities. The data is captured and then collated at the national level so that they can get a view of the total number of PrEP initiations. I think some of the challenges with the data collection system are that it's not a cohort data, so it's quite difficult to track individuals' journeys and their transition to different PrEP methods over time, but it is something that we are working on. And also that the facilities, although they do report up to the next level in terms of the district, then the provincial, then the national level, the individual primary healthcare data collection units are not linked. So if an individual moves from facility to facility, it's not always easy to get that individual data. But it is something we are working on. There are some other systems that are used by the Department of Health for some other health programs, and we're looking at leveraging that particularly for lenacapavir, where we know with the longer follow-up period, there's a real chance that people may move from facility to facility. So we're looking at options for that.
Thank you, Catherine. There is one more question in the chat regarding primary healthcare facility. When the patient get the PrEP in primary healthcare facility, can he or she be tested also in primary healthcare facility? Or only?
Yes. Yes,
You.
our primary healthcare facilities are the backbone of the South African health service. So generally they are led and run by nurses, but you can get a comprehensive package of service there. So nurses are able to conduct HIV testing, STI syndrome screening, they provide STI treatment, they prescribe and provide oral PrEP, cabotegravir ring, lenacapavir. They also can treat minor ailments. So most of the services in South Africa are provided by nurses. And then, if there's complex conditions, there may be a doctor in a facility once a week to see them, or they would refer up to a hospital for hospital-based care. And then on the other side, we do allow and support HIV self-testing using self-screening kits. In some areas, it's stronger than others. We have community health workers who are also able to go out into the community and conduct HIV screening and testing. They're not able yet to deliver PrEP, but something to work on as well.
Дякуємо. Беззаперечно, це новий досвід і в частині nurse-led PrEP, і інші речі, які ви кажете, це, мабуть, може бути наступними кроками в розвитку доконтактної профілактиці в Україні. Тож дякуємо дуже, що поділились з нами своїм досвідом. Що ж, мабуть, на цьому етапі ми перейдемо до іншого запрошеного учасника сьогоднішнього нашого вебінару. Це докторка Бренда із Бразилії. Пані Брендо, будь ласка, запрошуємо вас поділитись вашим досвідом. Просимо тримати вимкнене у той час, коли презентують наш матеріал спікери, оскільки це дуже важко залишатися в тому ж потоці, в якому доноситься матеріал. Дуже дякую. Бренда, будь ласка.
So, dear Brenda, shall I share your presentation now?
Yes, please.
Yes.
Thank you.
Yes.
Good morning, good afternoon for everyone. I'm Brenda Hoagland. I'm from Brazil, from Fiocruz Foundation. Thank you for the opportunity to talk about the lessons learned with the introduction of long-acting PrEP in Brazil. Some of the background of the region: Latin America is one of the few regions where new HIV cases have continued to rise since 2010. The disproportionate burden of HIV epidemic is in young persons from sexual and gender minorities in the region. Oral PrEP scale-up has been very slow, and adherence to oral PrEP remains a challenge, particularly for those under high vulnerability. Next one, please. Here is the map from Brazil and some information about oral PrEP implementation. At the moment, we have 1.2 thousand public service that offers PrEP, oral PrEP with no cost. But as you see, most of these services are in the south and less in the north. Since the implementation of oral PrEP in public health, more than 300,000 persons access PrEP, but at the moment, half of them are using regularly. So there are still gaps. In the last 12 months, around 34% of the individuals that had at least one dispensation of PrEP discontinued PrEP, and this most happen in Black and mixed Black individuals, the youngest one, and the transgender people. So our studies try to understand the PrEP preference of individuals. This is a study conducted in PrEP. This study was conducted in 2020 and is a discrete choice experiment that interviewed around 4,000 participants. And at that time, we already saw that the frequency of use was an important point. Most of them at that time already said about a monthly PrEP or a 2-month PrEP or a 1-year PrEP. Next. Other surveys, one conducted in 2021 in Latin America in 3 countries, Brazil, Mexico, and Peru. We interviewed more than almost 7,000 participants. And at that point, most of them was interested in an oral PrEP that could be taken monthly, or an injectable PrEP that could be taken at each 2 months. Then we repeat this interview only in Brazil with almost 4,000 participants. And now, more recently, people are talking about the 6-month PrEP already. So there is a strong preference for long PrEP alternatives for these individuals. Next. I will talk now about our InPrep CAB Brazil study. That is the study to generate critical evidence to inform national policies and programs implementers about optimizing delivery of CAB-LA PrEP for MSM, non-binary, and transgender individuals within public health PrEP service. Next. This study was conducted in 6 public PrEP services in Brazil in 6 cities, and the study population was individuals with 18 to 30 years, identified at MSM, non-binary and transgender persons with an HIV negative test that came to this service looking for PrEP or HIV testing. Next. We had done a lot of formative research with community mobilization, process mapping the service, how to offer an injectable PrEP in a service that already offers oral PrEP, and some focus group discussion. Next. And we developed this mHealth intervention that is some small videos in the tablet where the individual can look by himself for information related to oral injectable PrEP and other strategies for prevention of HIV and STI. Next. And here we have a summary of the study design. So participants interested in PrEP that came into the clinics had performed their HIV and STI testing. Those with an HIV negative test had the opportunity to receive the information about PrEP prevention methods by a counselor, or part of them received the mHealth, the tablet with the information, plus the counselor. And at that point, they could have a choice. Some could choose oral PrEP, some may choose CAB-LA. Those who choose CAB-LA perform a viral load HIV with the GenExpert, and with a negative result in the same day they receive their first injection of CAB-LA. Next. So from October 23 to September 24 was the enrollment period. Around 3,000 persons were evaluated, and from them 1.4 thousand participants was enrolled, and 83% choose CAB-LA. Next. Here is some baseline characteristics of the cohort. Around 40% have been included with 18 to 24 years. Most of them were cis MSM, and around 60% was Black or mixed Black were included. Next. And the main reason for choosing oral PrEP was fear of injection. And the main reason for choosing CAB-LA was difficulty with daily medication. Next. We see that the factors associated with choosing CAB or oral PrEP, we see that to 18 to 20 years and those with higher decision of conflict were more likely to opt to oral PrEP, while those exposed to mHealth intervention and reporting condomless anal sex were more commonly choosing CAB-LA. Next. In our formative research, we had 120 interviews, and here we see the reasons for choosing or not choosing the different PrEP options. So the reasons for choosing CAB-LA, the most response was perceiving convenience, practicality, easier adherence to bi-monthly injection, and higher efficacy compared to oral PrEP. And the reasons for not choosing CAB was fear of injections and local pain. And the reasons for oral PrEP was perspective of less clinic visits, easy for daily adherence, availability during travels, and ability to stop to any time if need. And reasons for not choosing oral PrEP was forgetfulness of daily intake, gastrointestinal side effects, fear of inadvertent disclosure, and fear of judgment by family. The mHealth was perceived as highly desirable and useful for PrEP education, having the potential to be implemented in HIV prevention services. Next. One other intervention pack that we performed in this study is that in Brazil, all the antiretroviral dispensation is controlled by a logistics system called Cyclone. So the CAB-LA PrEP was included in this system, and this way the pharmacists could receive alerts about injections that are delayed and could send messages to these individuals informing the delayed and rescheduling their consults. In our study, we had a high proportion of adherence. Around 94% of all injections were performed on time. Next. And when we see the PrEP coverage around the two cores, we see that 95% of the individuals were covered by PrEP with CAB-LA. When we compare to oral PrEP, only 53% was covered in all the days. The coverage for our oral PrEP was made about the medication post-session ratio equal or higher 0.6, indicating 4 or more pills taken by week. Next. And the study follow-up, what we see related to the CAB-LA choice cohort. We had 7% of loss of follow-up, and 0.8 had only one injection, received the first injection and did not come back anymore. Around 6% needed a reload. He needed to reinitiate CAB because he was late with his injection. 9% switched from oral PrEP to CAB-LA, and the main reason was preferred not taking pill. They changed their decision. They had side effects, and only 4% switched from CAB-LA to oral PrEP, and the most reason was local pain with injections or traveling, or only the preference of stopping CAB-LA. So the next, please. We have here some highlights and lessons learned. The InPrep CAB Brazil study is the major implementation study in Latin America. Comprehensive training for providers is essential to ensure tailored and effective counseling for PrEP users. The great majority of participants that choose CAB-LA, and mHealth played an important role in PrEP choice and support participants' decision-making process. A very high proportion of injections were performed in time, and this persists through the follow-up, combined with a low proportion of loss of follow-up among those who choose CAB-LA. The intervention package has a potential for scale-up, enhancing adherence monitoring, and ensure continuity on care on a broader scale. Availability of LA agents significantly improve PEP coverage, underscoring its potential as a tool in addressing adherence challenge with daily oral PrEP, particularly among this population. Next. And what new? LAN-specific questions on the drivers for uptake and delivery need to be answered. What are the optimal ways to deliver scale-up LAN PrEP, assessing how to best integrate its provision into existing PrEP service settings and or different healthcare delivery models? How can we better reach highly vulnerable populations that remain underserved and ensure their continued engagement in care? How can we ensure that the loading dose and administered not in initiation but also during reinitiation period? And how can the intervention package be improved to support its automated, scalable use across the country? So for these questions, now we developed the InPrep LAN Brazil study to evaluate the feasibility of implementation LAN for HIV prevention in real-world settings within the Brazil public health system to generate clinical evidence to inform national policies and program implementers. Next. This study will be conducted in 8 public PrEP services, including a mobile service to offer PrEP, and we will offer PrEP to the same population with an HIV test result, negative HIV test result, aged 16 to 30, could be PrEP naive or PrEP experience, and they are coming to the service looking for PrEP or HIV testing. Next. Next. The study schema is similar to the CAB-LA study, where people will have the opportunity to receive at this time, all the individuals will receive the opportunity of information in the mHealth intervention tablet, could have their choice. At this moment, they will choose oral PrEP or LAN. And we will only perform the rapid tests. In a negative test, the person could receive LAN, but we will collect a blood sample to do locally viral load with the COBAS. So this result of the viral load will be checked in his next visit that will be performed 30 days before. Next. And we will have the intervention package using the cyclone, so we will control the injection visits, and the pharmacist could contact participants that have their injections delayed. But Cyclone now will be developed to send message by WhatsApp message reminders related to their visits and to their injections. So this will be new. And we'll send message to remember participants to take their loading dose that is done. Next, please, sorry. Next. And we will send reminders to the participant to remember them about the loading dose that is taken in the day before of the first visit. So in the first visit, they will take 2 tabs and 2 injections, and the next day at home, they have to take 2 tabs again. So for this 2 tabs, we will send a message remembering them about this tabs that needs to be taken. Next. So my acknowledgements for all study participants, the study sites. These studies are supported by UNITAID, Brazilian Ministry of Health, and we've donated CAB for the study. Thank you. Next. Thank you.
Thank you, Brenda, for your excellent just presentation. Дякуємо, Бренда, за вашу чудову презентацію. В нас є декілька питань від учасників в чаті. І, будь ласка, Яніса піднята рука. Яніс, будь ласка.
Thank you very much, Marina. Sort of maybe if we can flag those questions after to Brenda. But first I wanted to say thank you very much to Brenda and all the Brazilian colleagues, because they do lead on PrEP implementation in Latin America and the Caribbean, and they're one of the sort of leaders in innovation around PrEP service delivery. So thank you very much, Brenda, for sort of this very important insight in how you've implemented cabotegravir. One of the key things I think we can all appreciate is making sure that with injectable PrEP, whether it's cabotegravir or lenacapavir, that people show up for their follow-up injection visits. So it's very interesting how you showcased the Brazilian system, Cyclone, if I pronounced it correctly, where you're able to, where the pharmacist, if somebody did not show up, the pharmacist followed up with the client, is how I understand it in PrEP CAB. Is that correct?
That's right.
And were there other people sort of in the PrEP care team, for example, the nurse or an outreach worker or social worker from the NGO working at that PrEP site that also tried to send reminders to people prior to their injection CAB visit?
Yes, we have this cyclone that it's very important for us, and that's why we're using. All service that offers PrEP needs to dispense PrEP using the system. So the pharmacist is receiving this report because it's the pharmacists that directly work with the system. But you could give access to other member teams if you want to receive these reports. So other members in the service could access these reports and contact. So in CAB, the pharmacist sent this report to the study members to make this contact and call them back. And now for LEN, I think you saw there, we are planning to the system send messages directly to the individuals, because this system has all the information about the individual, the address, the phone number, so we could put this linked to the WhatsApp and automatically send this message for the next visit, because as you dispense the prep, you already know when the next prep should be done. So you could plan all this and automatically you send these messages to WhatsApp. So we are trying to innovate this time to something more automatic, but let's see if it's going to work, because everybody needs to have the WhatsApp. People needs to look the message, should accept to receive that message. So we know we could have some problems, but we believe it could be implemented in public health if it works.
Thank you very much, Brenda. I think this also warrants, after this webinar, probably a follow-up with our Brazilian friends on how you're integrating these digital solutions in your PrEP delivery. I think this is really critical, something that, of course, Ukrainian partners are very much also on the forefront, the application of digital solutions in HIV prevention and treatment. Marina, may I sort of over to you related to additional questions in the chat? Thank you again.
Дякую, Яніс. У нас ще було одне питання в чаті від пані Ліліани Кваші. Ось питання заключалось в тому, які ще дослідження проходять учасники, окрім тестування швидкими тестами на ВІЛ.
Yes. So in Brazil, the algorithm test for HIV infection identification is only using using third generation rapid tests. So we have third generation rapid tests in all service by free, and we have an algorithm that we use 2 rapid tests to make this diagnosis. We have in public health a viral load platform, COBAS, but we only use the viral load if you need to identify some tests that not conclude. Some service could have different serologies, but they are not widely available in the country. But we could have an ARC-TET for some service, but that's not part of the algorithm. The algorithm is all used with rapid tests. It's offered by free self-testing in all countries. People that are using PrEP could take with them self-test to distribute. I didn't talk about that, but it's something that we already implemented. So anyone could look for self-testing to take for their home, or the PrEP users could take in their visits some tests to use for their own or to give to friends. And at the CAB, we had used the Gene Expert, that is a point of care viral load, because at that moment we were really worried about injecting persons that could be at acute infection and the test didn't detect it. I didn't show this result because we are still we will show these results, I hope, hopeful at CROI next year. But we saw some difficulties with this test because it's point of care, but it takes 90 minutes to you have the result. So somebody that's coming for PrEP will need to have around 2 hours, 3 hours to conclude the visit. We didn't find any acute infections in these participants, but this is something that we will present in the next Congress. And we were worried about that because of how CAB works and how it's difficult once you inject CAB to identify a HIV infection. But we believe that for LAN, we're gonna use what we have already in public health, that is the platform of COBOT, viral load, and we will collect, but we will not wait this result. We will collect and check this result as soon as available. If this a person have acute infection identified, so he will migrate to treatment. If it's not identified, he will go on, and we will keep using the third generation RAP test for checking the HIV, the possibility of infection. I hope it's clear what I explained. Sorry.
Thank you for the Martin response. It's pretty clear. Dear Ioannis, please.
I'm not facilitating, I'm participating, so apologies to Marina. And I know we've gone over time. I'm mindful of everybody's generous contribution, and we still have over 228 people still past the hour, which is a sort of a testament to all the real interest in this topic, and Catherine and Brenda for joining us today, and also our dear PrEP user from South Africa. Just a final question, I think on, not in a reflection, maybe on that, Brenda, related to in Ukraine, when we convened the technical working group for developing the cabotegravir PrEP protocol, we had discussion as to whether to go for the WHO-based recommendations on HIV testing for CAB, or consider at that time the US CDC guidelines, which also were including PCR viral load at baseline. And so from what sort of you've indicated, we sort of can be rest assured that that sort of more costly and time-consuming approach of using GeneXpert at baseline is not probably in line with the public health approach, correct?
Yeah, I think it's too expensive. It's hard to perform, and I think it was not really useful. So I think that we should not think using viral load to offer injectable PrEP. I think we should use our tests, available tests. Of course, we should talk a lot with the participants, understand their risk, understand if that moment he needs PEP and not PrEP. So I think this is most important in the process, in this first visit, understand the sexual risk, what is better at that moment, but use the testing that it's available. I think viral load, it's not really helpful if you want to implement in all your country. We use because we are doing a study, we want to answer some questions, we want to be secure about answering these questions, but we think that the available tests is okay to initiate PrEP, oral PrEP and injectable PrEP. And it's important to mention that in Brazil, oral PrEP is with no cost in public health. And now not only physicians, but nurses and pharmacists can prescribe PrEP now. This is a decision to offer more PrEP and other services. And we are working a lot with other options as telemedicine and mobile services and NGO. We are trying to see different ways. In the São Paulo city, maybe you know, we have these machines that you could take the PrEP. So person have a teleconsultation, receive a prescription with the QR code and go to the machine and take his PrEP and his self-testing. We are using self-testing on the follow-up for oral PrEP. So since we initiate there in 2018, a lot of changes to facilitate the access to oral PrEP are done in the country, but still challenging.
Absolutely. So thank you very much, Brenda. I think we are quarter past after the allocated time, but it's just everybody's excited about the topic. I'm always excited about the topic. And it's really great that we've had this collaboration and discussion across 3 continents this afternoon and morning on long-acting PrEP and sort of the promise of long-acting PrEP in our countries. So that's all from me. Over to you, Marina.
Так, Яні, дуже дякуємо. Перед тим, як завершувати наш захід, у нас ще була піднята рука в доктора Кетрін. Будь ласка, якщо ще актуально, ми б хотіли почути вашу думку.
Sorry, I didn't mean to keep you longer than I needed to. I just wanted to say that in our program, we also looked at the baseline viral load testing and did not find that it was needed. We also found that the rapid testing was the way to go to improve access. I can send you a poster that we presented on that information, but I think it also is reassuring that the HIV rapid test is the way to go, and that's what our guidelines recommend as well.
Thank you, Catherine. That would be really great, actually, indeed, because I think it's a key discussion point amongst, right, around our colleagues in our community. Thank you.
Так, дякуємо дуже, будемо чекати на ці матеріали. Що ж, на цьому ми завершуємо наш 3-денний вебінар. Ми дуже хочемо щиро вам подякувати кожному з вас, хто під'єднався, за цю готовність відкривати для себе і впроваджувати нові підходи у сфері профілактики ВІЛ-інфекції. Не роблячи довгих оглядів, але ми розуміємо, що це 3 дні були насичені матеріалами, більше навіть практичними досвіду впровадження інших країн. У нас було 3 континенти, і кожна презентація, кожна дискусія, яка відкривалась тут в чаті і голосом, вони формулювали в нас спільне бачення, яке сьогодні надзвичайно важливе. І хочеться наголосити на тому, що неодноразово говорили наші міжнародні спікери, що ДКП – це не тільки, власне, про сам препарат, який ми призначаємо пацієнту для профілактики, або про клінічний протокол. Це про те, що ми пропонуємо, що ми маємо цю клієнтоорієнтованість, повагу до людини і про те, щоб вона мала можливість вибору, те, про що казали, з багатьох варіантів, які ми пропонуємо, обрати саме той метод профілактики, який найкраще відповідає її житті. Тобто це вибір і про ефективність, і про прихильність, а вже ж це про безпеку. І варто зазначити, що скоро в Україні ми будемо мати теж вже 3 з 4 існуючих у світі продуктів з доконтактної профілактики, окрім вагінального кінця. І це означає, що Україна стає країною, де кожен дійсно пацієнт може обирати цю терапію, оптимальну для нього модель профілактики. Тобто, або це модель за потреби, доконтактна профілактика, або щоденна, або це довготривала ін'єкційна форма, про які ми почули дуже багато від тих спікерів, які змогли долучитись до нашого заходу. І Хочеться сказати, що всі продукти забезпечують дійсно високий рівень захисту від ВІЛ, але на чому наголошували наші спікери, лише за умови правильного його використання, і це є теж дуже важливим. Про контекст України ми чули, що, і ми знаємо, що Україна є один із перших проходців в Європі, але в період повномасштабної війни це прям така дійсно похвала, яку це дуже важко робити, коли ми кажемо про профілактику. І на цьому моменті я би хотіла дати можливість ще для фінального слова фахівцям Центру громадського здоров'я, які очолюють всі заходи і є тим, власне, локомотивом, який тягне профілактику ВІЛ вперед.
Колеги, доброго дня. Від імені Центру громадського здоров'я хочу висловити величезну таку подяку всім учасникам, міжнародним експертам, учасникам з України. От саме за живу дискусію, за обмін досвідом. От дуже швидко 3 дня пролетіло під час вебінару. Ми переконалися, що це найефективніший метод профілактики ВІЛ-інфекції. От наш спільний обов'язок зараз в Україні забезпечити сталість програм, якість, доступність до кожного пацієнту. Коли ви, міжнародні експерти, ділились своїм досвідом, вам величезна подяка. От був чесно вражений, знаєте, от моментами ми розуміємо, як надавати доконтактну профілактику з точки зору медичних підходів. Був дуже вражений те, як ви ділились гнучкими моделями надання послуг і вашу реальну орієнтацію саме на безпосередню потребу окремої людини. Це було нове, це нам дуже потребувало. Україна зробила величезний крок в плані доконтактної профілактики. Нам ще залишаються певні моменти, звісно, потребує інвестиції в навчання персоналу, в навчання лікарів, навчання неурядових фахівців неурядових організацій для розширення послуги, для посилення роботи з ключовими групами, зниження стигми, тобто є куди рухатись. І тут хочу подякувати, знаєте, за цю можливість поділитись досвідом, обговорити і знати щось нове. Всім вам, учасникам з України, міжнародним експертам, нашому національному координатору доконтактної профілактики персонально Діані Шевченко за величезний внесок в підготовку, організацію заходу, колегам, вам, присутнім з Бюро ВОЗ в Україні, фахівцям ВОЗ, от саме за обговорення, за дискусію, за відповіді на питання. Тому ще подякую перекладачам за можливість синхронного перекладу і за можливість вільно, одночасно, одномоментно розуміти, що говорять фахівці, міжнародники. Тобто переклад був чудовий, величезна вам подяка. І всім нам тоді на завершення плідної роботи в сфері доконтактної профілактики, тому що, справді вже неодноразово говорилось, що кінцевим бенефіціаром, отримувачем послуги є окрема людина, яку можна, є ефективні заходи, можливості, засоби вберегти її від інфікування ВІЛ, тому всім натхнення і подальшої плідної роботи. Дякую.
Дякуємо дуже, Сергію. На завершення декілька слів буквально щодо сертифікатів. Як ми анонсували, наш захід передбачає надання всім учасникам, які прослухали серію вебінарів, отримання сертифікатів від Всесвітньої організації охорони здоров'я. Хочу звернути увагу, що це не ті сертифікати, які дають бали безперервного розвитку, але це сертифікати від міжнародної організації на основі пройденого вами матеріалу. Тому вам у найближчі дні після завершення буде розіслана форма зворотнього зв'язку. Вона не буде містити технічних питань щодо, власне, прослуханого матеріалу, але ця форма дасть нам змогу надалі організовувати навчання так, щоб воно було максимально корисним для вашої практики. Тому, будь ласка, на основі ваших відповідей ми зможемо сформувати ці сертифікати і надіслати. Просимо заповнити їх до кінця цього тижня. На цьому, власне, в нас вже дійсно завершення. Ми щиро дякуємо вам за те, що під'єдналися і були уважними, активними і зацікавленими дійсно в розвитку доконтактної профілактики в Україні. Ми дякуємо всім міжнародним експертам, які були з нами ці дні, і партнерам з Центру громадського здоров'я за підтримку цього заходу. А вам, шановні лікарі, ми щиро бажаємо сили, натхнення, упевненості в вашій роботі, і хай кожний пацієнт, який буде звертатися до вас по профілактику, отримує не лише якісну допомогу, але й право на вибір, і вибір, який захистить його життя і зробить його мобільним. Тому ми дякуємо вам за ці 3 дні, бажаємо вам гарного вечора і до нових зустрічей. Слава Україні!
До нових радісних зустрічей, колеги. Бережіть себе, будь ласка.
Дякую, до побачення.
До побачення.
Дякую, до побачення.
Дякую, до побачення.
Thank you so much to everybody. Stay well and safe. Take care. And we'll be in touch soon. Great to see you, Sergey.
Дякуємо.
Дякую.
Вам дякуємо за час.
Дякую.
And our dear Dimitro, our translator, our